All right, we are moving right along. I'd like to welcome Sahil Thakur to the stage. Sahil will be presenting enhancing cardiovascular disease risk prediction using metabolic profiling in the UK Biobank, Pooled Cohort Equations versus retinal imaging-based Dr. Noon CVD. Sahil?
Hi, good afternoon, everyone. On the last day of the conference, thank you for being here. I would like to thank the organizers for having me present this interesting work. Again, I'm an ophthalmologist by training. Please feel free to take images of the presentation. I feel these will be very interesting findings for all practitioners of different domains. So, just a little bit about me. I have academic positions at the Singapore Eye Research Institute and the Duke NUS. A little bit of disclosure. So I'm an employee of Medivale. Unrelated disclosures are there as well. So I work with a few other organizations. Essentially, the talk schematic is going to go this way. So I'll talk about what Dr. Noon CVD is. Again, it's something new, so we need a little bit of background about that. Then we'll see what the methodology was followed for the study, the results, the discussion, and the conclusion, and why it matters for all of us here. So we know that metabolomics have been used across medicine for different things, especially with the personalized medication approach and the personalized care approach that is being advocated across specialties. So for biomarker discovery, precision medicine, novel insights, metabolomics are the closest to the phenotype, so they have a lot of utility. So metabolic profiling has been tried to be added on to existing risk calculators as well. So this was a very interesting study, again in the UK Biobank. So they tried to add metabolomics to QRisk. They showed that it doesn't do anything and QRisk is already good enough. However, what's interesting here is, again in the UK Biobank, when they use a different kind of a score, this is score 2. So when metabolites are added on to score 2, actually there was an additional benefit there. So the C index is improved. So again, we decided to kind of see that there is some amount of discrepancy here. So we tried to see, let's compare it with our retinal biomarker as well. So just a little background about the retinal biomarker. So this was our foundational paper. It was published in the Lancet Digital Health. Essentially, the idea is very simple. So you take the retinal images, you train an algorithm that can identify patterns from the retinal images to predict coronary artery calcium. And once you are able to predict coronary artery calcium, you can do risk stratification for patients. So this is how the flow was. So there were a lot of images that were involved in the training data set. Anyone who wants to look at the paper, they can scan this QR code and see the foundational paper. So these are people who have had the CT scan and the fundus photo done at the same time. Then they pass through a deep learning algorithm. The algorithm learns the patterns between the retinal image and the CT scan. And then what you get is a retinal CAC analog. And once you have that, what you are able to do is something very cool. So these are Kaplan-Meier curves which show the performance of the retinal biomarker as compared to the CAC. So you can see the risk stratification is very similar across the two. And what we showed in the paper additionally was that it has an additional incremental value as well when compared or paired with the Pooled Cohort equation. So going on, in this study, we tried to see, can metabolites improve performance of the retinal biomarker as well? And we wanted to compare it with the Pooled Cohort equation. So our hypothesis was metabolic profiling actually improves the performance. And we are comparing it with the Pooled Cohort equation. So for the methodology part, UK Biobank, I'm sure a lot of you would be aware it's a very large data set from the UK. There is a huge amount of data of different parts of the body. For this, we are using the vision and hearing data, which are the retinal photos and the metabolites, along with the cardiovascular outcomes. So this is what the flow looks like. So UK Biobank has about 86,000 individuals who have fundus photographs. Without metabolites, a large data set. It's about 66,000 of them, CVD events, and about 2,000 individuals. And with metabolites, we have about 16,000 individuals and CVD events of about 540. Then we did a Cox lasso model. In this, we added on the metabolites, and we have a model in which we can compare retinal biomarker performance. We can compare the Pooled Cohort equation, and then we can compare compared models or combined models in which the metabolites are added onto these. So just look at the population characteristics here. So there are the overall population, the no event rate population, and the CVD event rate population. Essentially, people who have had CVD events were more likely to be males, smokers, higher systolic BP, diabetics, and on cholesterol-lowering drugs. So this is, again, something which we see across populations. So when we look at the metabolites, 19 metabolites were found to be associated with CVD incidence. A lot of them are from the lipid subgroup, glucose-related subgroup, some amino acids, some plasma proteins, and the renal function biomarker, which is creatinine. The interesting part is albumin, creatinine, glucose are metabolites that are consistent across the previous papers and our paper as well. The lipid biomarkers differ by a little bit, but essentially are reflecting the same kind of metabolite risk for CVD profiling. So this is the lasso plot, which kind of shows how we did the lasso regression for this and how we came to the 19 metabolite number. Going on, we also did some additional literature-based analysis to look at these metabolites. These metabolites are associated with a lot of different types of diseases across the body. So we did a heat map to see a lot of these metabolites have been also previously kind of shown, sorry for the small font, but they have been associated with obesity, with cardiovascular disease, with dyslipidemia, and a whole shenanigan of factors that you see with cardiovascular risk. So let's come to the results. So the metabolites had a C index of about 0.667. The retinal biomarker outperformed everything else with a C index of 0.711. And the pooled cohort equations had a C index of 710. Again, very close to each other. But the interesting thing here is metabolites alone are not as good as the pooled cohort equation or the retinal biomarker. Let's look at the combined models now. So when the metabolites are added on, there is an incremental benefit for both the retinal biomarker as well as the pooled cohort equation. The pooled cohort equation actually improved more, and the best performance that we got in the study was actually with the pooled cohort equation, which is 0.739. Again, you can see the differences are in the third decimal place, which means essentially the performance of the traditional risk calculator, which is pooled cohort equation, and the retinal biomarker are very similar to each other. But we know that when metabolites are added on, the performance of both of them increase. So we did a subgroup analysis to look at people of different glycemic status. So this is people with diabetes, pre-diabetes, and no dysglycemia. The interesting thing here was even though traditionally it is thought that the retina would have performed best for the diabetics, we saw something else. We saw that with the metabolites, we had a 12% increase in the performance for the retinal biomarker. But for the other conditions, the retina outperformed the pooled cohort equation. Going on, when we look at the other indicators of how performance improvement can be measured, so we also did the classification improvement. So it was positive for both the retinal biomarker and metabolite model, as well as the pooled cohort equation and metabolite model. And there was an integrated discrimination improvement as well, even though it's a very small number. The interesting thing again here is when we look at statistical testing between the performance, there is actually no difference. You can see the difference is there in the third decimal place again. So what does this mean? Essentially, from the study, we can see that the metabolic profiling, it improves the CVD risk prediction in UK Biobank when combined with the traditional risk calculator, which is the pooled cohort equation in our case, and or with the novel retinal biomarker. The C index performances are very similar to each other in the range of 0.73. And in diabetic individuals, we observed a 12% improvement in the C index, especially for the retinal biomarker with the addition of the metabolites. So why does this matter? So with this, we show that for traditional CVD risk stratification, the performance of the retinal biomarkers are as good as traditional risk calculators. But the unique part is retina is non-invasive. It is accessible easily. We have previously in our work also shown robust performance across different subgroups, and it opens our eyes towards the new exciting field of oculomics. So I'll just end with an acknowledgement to the academic teams and the Medivale team that I've been working with. I'll be very happy to take any questions, and you can reach out to us for collaborations. Thank you so much.
Thanks for the talk. I didn't know much about oculomics before this. I had a question about the retinal biomarker. Would that be affected by GLP-1 receptor agonist use at all? Because I know, we're hearing more about how these drugs affect the eye.
Yes, definitely. But the simple answer is yes, they may. the complicated answer is we are limited by the data sets that we have. So for the training of these algorithms, we have used a large amount of retrospective data, and we know that at that time the GLP were not there. So we cannot actually measure that effect as of now. But the good part is we are actually having prospective studies ongoing right now with our group and a few other different groups. So we should have some evidence on that. But I'm being an ophthalmologist, I'm convinced, yes, it affects. Cool.
This is a great talk. I really enjoyed it. I just wonder, in the real world data, I know this is like 2 well-designed cohorts, like what percentage of the people with diabetes, they actually have retina imaging data? So I think for pooled equation, like this kind of risk prediction scores, the fun part is that the good part is that it's all the markers are widely available. I just wonder, because I'm not a clinician, I don't know like the proportion of people having this imaging data.
Sure. Thank you for that question. And that brings us to a very important point. I think for diabetes, everyone knows that microvascular complications, the neuropathy, nephropathy, and the retinopathy are critical biomarkers of also chronic disease prediction. So these microvascular damages have been known to kind of predict mortality in diabetics. So over the years, most of the countries have initiated diabetic retinopathy screening programs. So if you see even across the US, Singapore, most of the developed countries, they are very robust diabetic retinopathy screening programs already there. So anyone who's a diabetic, they are told to go to their eye doctor once a year. A lot of them are doing it using teleophthalmology. So it means retinal images are being collected for all of them. So it means the retinal images are there for all. But right now, most of the retinal images are just being used for diabetic retinopathy screening, which is essentially a waste of this data in a way, because the retina can actually tell a lot. So if you guys, any of you have retinal images, do reach out to us. We can do a lot of things with the retina. It's truly the window to your body, to your soul, actually.
Any more questions? So I've just got one. It wasn't the primary focus of your talk, but you presented it early on of the 3 CAC groups in cumulative incidence of MACE, and then your retina scan 3 groups. How do those overlap? Have you looked at that crosstab?
Yeah. So that's actually a very good question. And it's also very important if you looked at the grading that we wrote. So CSC, as you know, can go very high. You can have 500, even 1000 CSC. But typically when we did our analysis, we are taking into account what the AHA ACC guidelines say. So the most critical part is CSC of 0, which is the low risk group. And then we have people from 1 to 99 and then above 100, because over 100, there are again very clear guidelines about what should be done. So the risk stratification that we did, there is about, so the C indices, I'll come to the C indices first. So the C indices for the retina and the coronary artery calcium, they are in the high 0.8s, which means there is about 80% of the time they are overlapping with each other. But again, there are cases where there is a mismatch. So I'll also go into the details of where the mismatch is. So there are people who have been on statins for very long, which means that these are people who have highly calcified plaques. We know we want to do that because we want to make the plaques stable. But these people actually have lower risk on the retina. So what we observe is if someone has been on statin therapy for very long, especially we in our internal studies see a range of about 15-20 years, then we observe that there is a mismatch between the two. But there's another group as well in which the CSCs are 0, the retina shows high risk, you do a CTCA or you do a carotid or you do angiography and you see soft plaques and you actually see blocks. So we are right now preparing a very unique cohort in which CSC is 0, retina is high risk, and interventions have been done for the patients. So there are use cases in which the retina and CSC don't match 100%, but for a naive population where the treatment has not been done but have the risk factors, the overlap is quite significant. So the performance is very similar to each other. Does that answer your question?
Yeah, thank you.
Cool. Thank you so much. Thank you so much.